Next we'll take a look at the lower quarter screen. Again, lower quarter screen, just like the upper quarter screen, it's done quickly to be efficient, but not so quickly you miss anything. So you can rule things in, you cannot rule things out. If you get any positive findings, meaning weakness, pain, decreased range of motion with an upper quarter screen, you want to look more thoroughly into it later to diagnose the potential pathology. So again, this is a screening, but it does give you clues on something that might go wrong. So starting lower quarter screen, we'll start at the lumbar region, we'll go to the SI region, the hip, the knee, and the ankle. Okay, let's have you facing straight away here, and then bend forward as far as you can. So checking lumbar flexion, checking again for how far the person goes, quality of movement, see if they have any discomfort. You okay with that?
Yep.
Okay, I stabilize, give some overpressure, and that could elicit some increased range of motion, some discomfort. Let's have you go backwards. I want to be careful with extension. She doesn't fall, goes back, stabilize posterior, some overpressure anterior, very good. I'm going to have you bend to your left as far as you can. Let them go through the full range, stabilize, give some overpressure. A lot of times with the overpressure, you're going to get whole different symptoms with that. And then bend to your right. Very good. And now I'm going to have you sit down for a rotation. Sit down and wrap your feet around the table, chair, that's called a chair. Okay, and I want you to turn your shoulders as far as you can to the right. So actively checking for trunk rotation to the right, and then give some overpressure, and then to the left, and then overpressure. Because we're in this position, just to save time, I'm going to do checking for strength. So I'm going to hold her in neutral, hold right there, don't let me move you, and gradually give some pressure, so resisting rotation to the left, and then resisting rotation to the right. Let's have you stand up. Resisted trunk extension. I'm going to hold posterior, stabilize anterior, and resist slowly again. Checking trunk flexion. Again, this is a gross assessment. Side flexion, hold right there. Don't let me move you. Good. And then to the left, hold. And it's best to ask the patient to hold. Don't say push into me, or you'll be wrestling with the patient the whole time. Next, let's get you on your stomach on the table. Just looking at the sacrum, going down the level here, just a joint play. Look at the sacrum. Just checking for discomfort, for hypo or hypermobility, and again, just a spring test. Just take a hand in the mid aspect of the sacrum and a quick push down like that. Usually there'll be a firm pressure, but patient shouldn't have pain. If they have pain, that's considered a positive test. Let's have you back on your stomach, or on your back. Trying to trick you there. Okay, looking at the hip, again, this is a quick screen. You want to check it bilaterally, but I'll, just for visualization, I wouldn't lean over typically, but I'll start with the left hip. Let's have you bend your knee up and bring your hip up as far as you can. So checking grossly how far she can go actively, good motion. Passively, give some overpressure, see if that causes any discomfort. You can also check for abduction with that. So let's bring your leg out to the side as far as you can. You want to keep it in neutral. As far as you can, go a little further, good. Stabilize, and I'll give some overpressure with that. Okay. And then clear the other leg to the side. Relax this leg, and then into abduction, stabilizing, bring this leg, slide it over as far as you can, checking for motion. I'm blocking here, give some overpressure, again, checking for motion, but checking for discomfort, see if there's limitation with that. So we did flexion, we did adduction, abduction. Let's get you with this knee up here, checking hip internal and external rotation. So external rotation, have your foot come in like that as far as you can. I'm trying to keep this in neutral. Can you go any further? Good. Going to stabilize, block this, and give some overpressure. And then let's go the other way. Hip internal rotation actively, as far as you can go. Okay, block it here. Give some overpressure with that. Again, checking bilaterally. Let's get you on your stomach. Checking hip extension. Again, I wouldn't reach over like this, but you'll have the patient lift your leg up as high as you can. You want to block SI region and lift up. And make sure there's not substitution with lumbar extension with this, so you need to block with that. In some cases you can also have the knee bent, but tightness of the rectus femoris might limit the motion with that. Okay, good. While we have her in this position, we'll do resistance to the motion for hip extension. Let's bring your leg up again. I'm going to stabilize, ease the pressure in, hold it there, don't let me move you. So again, a quick assessment to check if there's pain, if there's weakness. Let's have you on your side, left side. Okay, we could also do this with her supine, but I'll show that in a second. Lift your leg up like so, and I'm going to push down, checking for hip abduction. Good. Let's get you on your back. Position doesn't really matter when you do upper and lower quarter screen. because again, it's not exact manual muscle testing, you're just getting a quick test on how much motion they have, how much strength they have. So with this test, I can slightly abduct, and I'll ask her to hold together like that, don't let me move your legs out. So I'm going to resist like that, checking for bilateral hip adduction strength. Conversely, I'm going to push and check for abduction strength. Try to go proximal to the knee so you're not putting a stress on the lateral collateral ligament or the medial collateral ligament. Checking for strength of the hip internal, external rotation. Be in this position, I'll ask you to hold it right there. So I'm checking external rotation strength. I'll resist here, checking internal rotation strength. While we're in this position, we can check the knee for flexion extension. Extend your knee, straighten out your knee as straight as you can go. Again, checking that actively. We could also do this seated. You don't want her to move around. Now if I extend, I get a little more motion, so she has slight rec bottom when I check that. Checking for strength of the knee extension. Resist here, block there, and check there. Good. Very good. Let's have you on your stomach. Checking for knee flexion, active range of motion. We're checking the other side now. Bend your knee as far up as you can. So checking actively, passive with overpressure. Again, see if there's any discomfort. Check the migration with that. We can check for hamstring or knee flexion strength. Mid-range, hold like so. You don't want too much flexion or she'll get active insufficiency and start cramping up with her hamstrings. Okay, very good. You can have a seat on the side now. Checking ankle motion, I could do that in a supine position, but I'll check this. Again, I'll just check one side now. You always want to check it bilaterally, and you would do it a little bit quicker than this, but I'm just going through so you can see these. Have your foot come up to the ceiling. Good. Check it for dorsiflexion. Stabilize, give some overpressure. Point your toe down. Block it posterior, overpressure. Good. Have your foot roll in like so. Good. Checking for motion, discomfort, and then go the opposite way. Very good. And resist like so. Now checking strength, quick test of the strength. Keep your foot there, don't let me move it. So I'm going to check for dorsiflexion strength. Hold right there. Plantarflexion strength. Inversion strength, hold right there. Good. And again, ease your pressure and don't go too quickly, and hold right there, checking for eversion strength of that. You can also check the toes, check dorsiflexion, plantarflexion of each of the toe individually if you suspect there's any involvement with that. So that's a quick check to rule out any joint pathology, possible tendon contractile pathology, and we'll look at the dermatomes and myotomes next.